You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. And she is also the director of the Adult CAR T-cell Therapy Program for Hematological Malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi everyone, I'm Tania Jain, and I welcome you all to Season 1 of the Medscape In Discussion podcast series on myelofibrosis. Today, we'll discuss the natural history and risk stratification in myelofibrosis with our guest, Dr. Pankit Vachhani. Dr. Vachhani is an associate professor of medicine at the University of Alabama at Birmingham. And at UAB, he's involved in multiple clinical trials as principal investigator, leads the Leukemia Transplant Working Group, and is the medical director of clinical research unit at UAB. His primary research interest is in heme malignancies, particularly MPNs and AML, where he focuses on developing novel and experimental therapeutics. Welcome to the Medscape In Discussion podcast. How are you doing today, Dr. Vachhani?
Thank you, Dr. Jain. I'm doing well and delighted to be here with you doing this first podcast of the series. Also, a nice and big hello to all our listeners.
Wonderful. Thank you. Yes, we're very excited about this series. We don't have a lot out there for myelofibrosis, so we're excited to get this rolling. You spend a lot of time thinking about myelofibrosis, taking care of patients with myelofibrosis. One of the things that we often think about or spend a lot of time thinking about is what is the natural history of this disease and how do we risk stratify patients in this chronic myeloid malignancy? We live in a bit of an embarrassment of the riches at this point with several risk stratification models that are out there. Could you shed some light onto the merits and the pitfalls? What is your practical approach, and how do you basically use the IPSS, the DIPS, the MIPS, and the soup alphabet that continues to grow?
Absolutely. Thank you. Yes, we do live in an era and in a scenario where we have so many different risk stratification tools. But let me first start by saying that when I see a patient and they ask about their diagnosis and what that means, what I tell them first is that myelofibrosis is a blood cancer. It's a neoplasm. And unlike solid tumors where we do staging, we don't do staging of myelofibrosis mostly because it's a blood cancer. It's there everywhere from day one. But what we consider as risk stratification is more or less the equivalent of that. Now, you brought up some of the many different risk stratification schemes that are out there. There were a few which were in existence in the previous millennium. We won't even go over there. We'll start with IPSS, the first one that you brought up, the International Prognostic Scoring System, which was published in 2009, meaning it was developed in an era where JAK inhibitors were not even there. In fact, that's one of the key points that I want to mention, that most of these risk stratification schemes use data from patients who didn't even get the JAK inhibitors that we now routinely use. So what's the impact of these on the risk stratification schemes? We don't fully know, perhaps, and most likely it is different. So IPSS was developed in late 2000s, published in 2009, and it takes into account 5 different items. Age being more than 65, hemoglobin of less than 10, white count of more than 25, peripheral blood blasts of 1% or more, and constitutional symptoms. So this risk stratification scheme was developed in a way that you would take these 5 factors at the time a patient was diagnosed of myelofibrosis and use a calculator, put these 5 variables into that calculator, and prognosticate into one of 4 groups. So that would be low risk, intermediate 1, intermediate 2, or high risk myelofibrosis. That was the old way of doing things. Then came along some more knowledge for us, whereby we understood that anemia or hemoglobin of less than 10 actually had more prognostic implications compared to some of the other points. And that led to the successor of IPSS, which is DIPSS, or Dynamic IPSS. Now, this gives slightly more weightage to anemia, but all the 5 points are the same 5 points as we mentioned before. And this is probably one of the most commonly used risk stratification schemes even today. The reason being that it's simple to do. We have most of these items available on any given day if you see a patient in the clinic. We have done a CBC, we know the age, and we know the constitutional symptom status. Even more knowledge led us to understand that not just having anemia, but actually requiring transfusions is probably a worse thing, meaning it weighs even more than just having anemia. We also understood that having low platelets or thrombocytopenia, platelets less than 100, is an additional risk factor. And we also understood that having unfavorable karyotype, meaning chromosomes which are abnormal, especially some of those abnormalities, we understood that those are also an independent risk factor. So all of these 3 points that I just mentioned, which is the requirement of transfusions, chromosomal abnormalities or unfavorable karyotype, and thrombocytopenia, were then incorporated into the DIPSS model and led to the generation of the third model, which is the DIPSS plus risk stratification model. Now, I like to use this model if karyotype is available, and I would suggest doing that if one has it available. But as you and I know, many times we don't have karyotype information available because the marrow was a dry tap or various other reasons. Now, before we go further, I do want to make a couple of additional points. One is that point about constitutional symptoms. I think it's important to state right now that fatigue is not a constitutional symptom. It is a symptom, but not for these risk stratification schemes. What counts as constitutional symptom is weight loss of more than 10% in the previous 12 months, or unexplained fevers, or excessive sweats, daytime or nighttime, over the previous month or more. Now, when we take these 3 risk stratifications, all 3 of these give us a score which then leads to a 4-tiered risk stratification, as I had previously mentioned: low, intermediate 1, intermediate 2, and high risk. I think the common theme amongst all these 3 risk stratification schemes is that the low and intermediate 1 risk strata together count and constitute the lower risk myelofibrosis, while the intermediate 2 and high risk myelofibrosis constitute the higher risk myelofibrosis. So what's the difference then between these 2 lower and higher risk myelofibrosis? Well, the difference, simply put, is that the median survival, or maybe if we can extrapolate that word, the average survival for the lower risk myelofibrosis patients is in excess of 5 years, while that for higher risk myelofibrosis, it's less than 5 years, meaning there's more acuity, that there's more stuff that we need to do, probably more urgently, and we'll come to the transplant point maybe a little bit later. So these are the 3 big ones that were used for a long period of time, and then came along some additional ones. So there was the GIPSS, or genetically inspired IPSS risk stratification model. Now, this one is actually quite simple. It takes into account just the molecular gene risk mutations, which I think almost all of us obtain from peripheral blood or bone marrow samples, and either could be used. So it takes into account that and the karyotypic abnormalities. So in some ways, it's very easy to use. However, we don't really use this so often in practice because we don't know at what time point should we be using this risk stratification model. And for that matter, as we previously mentioned, not everyone has cytogenetics available straight up on day 1. So we have the molecularly inspired IPSS risk stratification models, also called as MIPSS. These were developed about 5-6 years ago. In fact, they are the recommended risk stratification models if one can use. So the first and foremost was MIPSS 70. And the goal over here was to develop a risk stratification model for patients who were potentially transplant eligible, so those who were less than the age of 70 or 70 years or so. And the goal there was to develop a risk stratification for their using more features, more molecular mutation data, or rather, use molecular mutation data. And that was good. It led to the use of 6 clinical risk variables, some of which we already talked about, like hemoglobin, white count, platelets, circulating blast, but also bone marrow fibrosis, constitutional symptoms, and a few mutations. So there were 5 high molecular risk mutations which were incorporated. These are ASXL1, SRSF2, EZH2, IDH1, and IDH2, and also one favorable one, which is a CALR type 1 or type 1-like mutations. So that was developed first. It led to a 3-tiered risk stratification. Then subsequently, after that, a MIPS 70 plus version was also released, almost simultaneously actually, and this took into account many of the same mutations, but only 3 clinical risk factors. However, it also added karyotypic information. So that led to that MIPS 70 plus risk stratification scheme, which is a 4-tiered risk stratification scheme. And finally, as an update to that, was the MIPS 70 plus version 2.0. Now, my point over here is that if you have the availability and the information of all the mutations, karyotype, and all of that, please use the MIPS 70 plus version 2.0. What's the difference between this and the other MIPS models that we talked about? Well, one, it distinguished the karyotypic abnormalities not just as unfavorable karyotypes, but it distinguished the very high-risk karyotypic abnormalities and unfavorable ones. So it gave more emphasis on very high-risk karyotypic abnormalities. It also identified and used a new mutation that was then discovered, which is the U2AF1, specifically the Q157 mutation, as an additional high molecular gene risk mutation. And last but not the least, it also used new sex and severity adjusted hemoglobin parameters. Let's keep in mind that most of these were made using the data sets which had primary myelofibrosis patients. So what about patients who had essential thrombocythemia before or polycythemia vera before and now have progressed to secondary myelofibrosis? Well, for years and years, we had been using the available risk stratification schemas, like, for example, DPSS, to even risk stratify those patients. However, there is, in particular, and I want to state this in case if anyone wants to do this, a risk stratification model called MySec-PM. It's called MySec-PM. And that's designed specifically for secondary myelofibrosis patients who, as a group put together, have better outcomes compared to the primary myelofibrosis patients. And all of these things are available as calculators, so it makes life easy in case if anyone wants to do. Just Google up and you will find a calculator to use. And so in those scenarios, especially secondary myelofibrosis, I would use that. In addition, Dr. Jain, there are a couple more risk stratification models that are available. And probably, if I may ask you about the MTSS model, which is the myelofibrosis transplant scoring system, in which scenarios would you suggest doing that?
Let me actually first applaud you summarizing all of the risk scores so nicely. We all use them all the time, but I never think of them in a sequence and really help sort of think of the evolution and how much we learn. I think one of the things that I always point out, and I agree with you, as you mentioned, you talk to your patients. I think one of the things that I also point out is these are guidance metrics. These are not perfect, right? I mean, I think the best thing that we get out of these models, each of which has its own perfections and imperfections, is it gives us a better understanding of what matters in terms of prognosis, what factors tell us that this chronic myeloid neoplasm has a faster pace to it in terms of progression to leukemia versus not. It's also always intriguing to me that splenomegaly, which is a big manifestation of this disease, and I cannot imagine is not a biological biomarker or a biological marker of disease severity, is not included in any of these, right? So we'll come back to RR6 in a little bit, but the baseline spleen size or the spleen size at any given time itself is not included. You asked me about what to use for transplant. So I will say that the most validated risk score in the context of transplant decisions actually still remains DIPS. The big CIBMTR study that was done by our former colleague and friend, Dr. Christina Gowen, which is published in Blood Advances using CIBMTR data, really still used DPSS information and stratified transplant versus non-transplant outcomes based on low, intermediate 1, intermediate 2, and high DIPS score. I will confess I use DIPS and DIPS Plus most commonly with incorporation of molecular data, whether it's in the context of MIPSS scoring system, which has its merits for sure, but certainly, does not include, for example, P53 or RAS mutations, which we know drive the prognosis in a certain direction, and usually the worst prognosis direction. The transplant, the MTSS is there. It includes some of the transplant variables as well, which is helpful, which is novel. But I think that data continues to get updated in terms of what donor outcomes look like. As you know, the recent analyses of donor types in myelofibrosis, which is a manuscript in process, did not show difference between mismatched donors and matched unrelated donors, which is something that was included in the MySEC scoring. So, kind of reflects upon how these are useful, yet recognizing their limitations. Dr. Ronnie Tamari also published a prognostic scoring system in patients undergoing transplant with the CIBMTR EBMT joint effort in Blood Advances last year. And despite its limitations, there is a meaningful use to it in the context of what's low risk, intermediate risk, and high risk, and includes age, includes hemoglobin, includes donor type as well in terms of the factors or the variables that are included in that model. I will come back to the point about spleen, and maybe I'll ask you to comment about RR6 here and how that change or response in spleen may or may not matter in terms of how we prognosticate patients or outcomes in the context of myelofibrosis.
Sure thing. Thank you so much. Yep. And I want to emphasize a point that you mentioned, and I fully agree, which is that we should not get too married with any of these risk stratification schemes, and especially with the answer of any of these risk stratification schemes for your given single individual patient who is in front of you. These are, as you mentioned, guidances. These are suggestions of what may happen, but every individual patient is different. The other point that comes up is what should we do when there's a discrepancy? Sometimes one risk stratification scheme might suggest that a patient is lower risk myelofibrosis patient. Another one might suggest a higher risk. A third one might suggest in-betweenness, or sometimes the variables that we put might be different on a given day compared to a week before, a week after. And I think, again, my point there is that these are guidances. We should be careful in how we use it. I think that the point where it becomes very important is the transplant candidacy and the time to transplant. So there for sure, we want to make sure that the high-risk myelofibrosis patients are getting transplant evaluations and early transplants. And to that point, Dr. Jain, you brought up the RR6 model, and I think that's a very good one to bring up here because, once again, every individual patient behaves differently, irrespective of what the risk stratification scheme might tell you or suggest to you. So where the RR6 model comes in, or RR6, which stands for Response to Ruxolitinib After 6 Months, is that this group of investigators from Italy, but also the model was validated from a cohort from Moffitt in Tampa, Florida, using an ambispective study, so part retrospective, part prospective. They set out to understand 3, or as many as possible, but it ended up being 3 factors which are easily available in the clinic for us to judge our patients on after they have been started on a JAK inhibitor. So I put it differently, irrespective of what their risk stratifications may have been at the original time of diagnosis, once they have been put on ruxolitinib, a JAK1, JAK2 inhibitor, and 6 months have passed by, what could suggest possibly to you that they are doing good or bad, or which ways are they going? And what they did and what they found was that the need for transfusions, let's say even at baseline or 6 months, or a less than impressive spleen length reduction and they came up with 30% cutoff. But I think what we should take home is that a less than impressive spleen size reduction, and the third factor being that ruxolitinib dose of less than 20 milligrams BID. If you have these three factors and you can put it in the RR6 model, you can then risk stratify patients into one of three groups: low risk, intermediate risk, and high risk group. It gives you a new baseline or a new time point to risk stratify patients on, to see how they are doing 6 months, or roughly speaking, there on a JAK inhibitor. This has been validated even in a retrospective study to understand whether patients could be referred early for allogeneic stem cell transplant or not. And possibly, we don't know for sure, but possibly one could understand whether some additional drugs could be added to such patients who are not doing so well, maybe other JAK inhibitors, transplant candidacy, as we already spoke, and other outcomes that could possibly happen. We ourselves are understanding more in the field in terms of molecular mutations. A few years ago, we didn't fully understand which mutations were bad and in what context. And we identified a few of them. But now we are understanding more of it. We know, for example, that ASXL1 mutation is a high-risk mutation to have. But we are now understanding even more that maybe its negative impact is primarily driven in the primary myelofibrosis setting, not secondary myelofibrosis setting. We are understanding more that having ASXL1 mutation is probably bad if it comes along with other high-risk molecular mutations, not as an individual entity. So a lot more needs to be understood by us, how these risk stratification models behave in pure JAK inhibitor setting, or especially hopefully in the future, a treatment stage where we are using combination therapies. That's something that needs to be seen. So this field will definitely evolve over time.
We're drawing close to the time, but I cannot let you go without talking about prefibrotic myelofibrosis. Dr. Vachhani recently wrote with a team from MD Anderson a beautiful review on prefibrotic myelofibrosis, which I do encourage people to read. Could you tell us, how do you think of prognostication in prefibrotic myelofibrosis?
Absolutely. So prefibrotic myelofibrosis is a distinct myeloproliferative neoplasm. First point, over the previous few WHO classification schemas, but especially starting 2008, then 2016, and 2022, the latest one. Simply put, its outcomes are somewhere in between essential thrombocythemia and overt myelofibrosis. First and foremost, let me just start by saying that there is no risk stratification schema that has been made directly from a prefibrotic myelofibrosis patient population that is directed just to them, that has been validated. So that's something that we need in the field more, and we need it with the newer therapies that are coming and the practices that we currently use. That said, IPSS is the one that has been used most commonly for prefibrotic myelofibrosis patients. Interestingly, intermediate 1 and intermediate 2 patient outcomes really didn't differ, and in fact, more in their median survival exceeded 10 years. So we should be a little bit careful in prefibrotic myelofibrosis when we use the IPSS risk stratification model and not subject these patients to, let's say, a more aggressive therapy. And I'm referring especially to allogeneic stem cell transplant prematurely or unnecessarily. So knowing these caveats is important. Now, could one use the MIPSS 70 models over there? Perhaps yes. In fact, there were some patients in the MIPSS 70 database, about 197 out of 700-ish patients, if I recall it right, who had low-grade fibrosis, so not the 2 or 3, but they had 1. Yes, one could use that. It's not very well validated in this scenario of prefibrotic MF. So my suggestion here is to use the IPSS, and if you want, maybe the MIPSS 70 or 70 plus models in that scenario. Now, one more thing that I do want to say about prefibrotic MF is that our day-to-day issues for these patients are actually more about thrombosis prevention or preventing hemorrhagic complications. And there, one may want to use the IPSET-T or the revised IPSET-T models. So that's risk stratification in some ways for the thrombosis part of prefibrotic myelofibrosis, not the overall survival part. conceivably, you could have a patient who is at high risk for thrombosis by the revised IPSET-T model, but is an overall low risk prefibrotic myelofibrosis from an overall survival standpoint. So we should keep these 2 points, distinct points in mind when we risk stratify. That's the short answer, Dr. Jain.
Perfect. Wonderful. I'm looking forward to when we know the genomics and the cytopenias enough to use a simple 1+1 model to help guide our decisions. But clearly, that's not going to be a reality. But I appreciate your time. I think this was a wonderful discussion. I learned a lot, and I hope our listeners did too. We will now end this session, and we will get ready for our episode 2 coming up on current landscape of treatment with Dr. Lindsay Jain. Thanks again, Dr. Vachhani. I really appreciate your time, and this was good discussion.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.